All right. Welcome, everybody, to our first Million Match teach-in for Hyp Care. This is Elle speaking. I'm going to introduce myself, and Audrey's going to introduce herself, and then we're going to dive right into a lot of information we have to share with you today. Auto captions should be on if you need them. If they're not on for you, go to the bottom of your Zoom screen and see if you can toggle those options. Either there'll be a button called CC or some little 3 dots menus you can navigate through. To give y'all a little visual description and introduction, again, my name is Elle, just like the letter L. My pronouns are they, them. I am a thin, tall, white hype with short brown hair. I'm wearing tinted glasses and over-the-ear headphones, a green turtleneck, and some little strawberry earrings that Audrey made for me. And I'll pass it over to Audrey to say hi.
Hi, everyone. Thanks for coming. This is Audrey speaking. Elle and I are going to split the presentation down the middle. So after this, I will be silent as much as possible. I am the other director of Hyp+Access, and can't remember if you said anything else, Elle, so I apologize, but I'll do my image description now, or my visual description. I'm a very average height, thin, white, hypermobile person. I have half brown and half blonde hair that's tied up in the back. And I'm wearing a brown sweater, and I'm in a room that has a little bit of a pink tint, light-wise, with some art on the walls. And to my left, there are red curtains. Right? I'm getting a nod from Elle. So yeah, I'll hand it back to Elle, and off we go.
Beautiful. Okay, I'm going to start sharing my screen. So there will be a switch in the screen that's coming right now. And we'll get into this presentation for y'all. So welcome and thank you again for coming. We are here for our first Million Match teach-in for Hyp Care. We are looking at a beautiful image designed by Chloe, our graphics person, showing a light gray rainbow sweeping across the screen, announcing the Million Match teach-in series with geometric flowers made of the pill shape for Hyp Care that are growing out of green hills. The text December 2024 through May 2025, which is the length of this campaign, is also sweeping across the screen. And you've got our goopy pink H logo and our name Hyp+Access at the bottom. So this campaign is launching right now with this teach-in and is going to extend through May to match 1 million to make Hyp Care happen. We're going to get into all the details. Going to the next slide. So this first teach-in is about Hyp. What is Hyp? Connective tissues and care access. So this is our first teach-in. We're here all together live on December 9th, or you are watching this asynchronously on our YouTube in the future. Hello, future people. And all of these slides that we're going through have a big bendy sweep across the bottom, starting in this dark navy color and transitioning to a bright pink with our goopy H logo on the navy on the left, unless they are a big gradient color that you'll see in a bit. All right. So some accessibility information for this event. As we said earlier, auto captions are on. We are going to try to speak slowly, but we struggle with that sometimes. So if we're not doing that, feel free to speak up in the chat and our team will let us know. As much of the chat as possible will be read aloud, but not everything will be possible. We'll try to read anything that's pertinent and certainly get into questions later, but only messages that are sent to all participants will be read, so not ones that you send to anyone privately. We will visually describe ourselves and the images we're looking at. And if you need additional live access support, please go ahead and message Roy in the chat, who I think is labeled Roy DM for Access. Roy is our new Communications and Programs Operations Manager. So thank you, Roy. And as a reminder, a properly captioned version of this teach-in will be uploaded to our YouTube channel for ongoing free access. And we want to let you all know that the sources for all the information we're discussing today will be posted to the event page on our website. And there's a link here for that, but we'll also share that all out in the email that we send y'all in follow-up for this live presentation, or in the YouTube caption if you're here on YouTube. All right. Next slide. So just a little agenda of what we'll be covering today. We're probably already behind because that's how we go, but we're going to start just with some basics about our organization, and then get into the teach-in content from about, it'll be more like 7:15 to 7:45 or 7:50, talking about what is Hyp. Then we will actually, we didn't fix this slide in advance. Apologies, everyone. We're going to take a break after the teach-in content and come back for the Q&A. And then we'll talk a little bit about Hyp Care and what we need from community to make it happen at the end. All right, next slide. So, Hyp+Access. Right now we're looking at a slide with a very deep, rich gradient moving from that navy to pink. And we're going to talk about who we are. Move into the next slide. So about Hyp+Access. We are a community-based nonprofit, right now transitioning into providing direct clinical and alternative care services. So our expertise is in supporting folks with connective tissue variance and overlapping conditions with a cross-disability solidarity framework. And since our official launch in 2020, when we became Hyp+Access, demand for our services has increased. 850% is the number that we have, but it might be more than that. And this is because our work meets a vital growing need for informed resources and accessible direct care. And you can learn more about what we do at hyp-access.org. Right, next slide. So some of what we do care access consulting and advocacy for patients and families. We are launching our medical and alternative program, Hyp Care, which we'll get into more later. We do ongoing peer and practitioner training in accessible touch therapy, a practice we developed called HAPT. You can learn more on our website while educating those folks about connective tissue literacy. We track medical science, care, and related systems impacting community well-being. A recent example is employment and healthcare, and we'll be releasing a report on that soon. We do lots and lots of public education on disability and connective tissue variance. We provide free resources for community. We do some accessibility consulting for organizations, and we offer a Hyp accessible dance improvisation class. And all these services are sliding scale and free if you need, which is very important to us. Next slide. Who leads Hyp+Access? We are multiply disabled people of all kinds. We are autistics for sure, lots of mad folks and psych survivors. We are queer and trans people, and we are multiply marginalized, multidisciplinary artists. which is where a lot of our backgrounds in this work really started. All right, moving on. This teach-in, of course, is for our Million Match campaign to get folks free education at the same time as making it possible to launch HypCare on the timeline it's needed. So on this slide, text reads, help Hyp+Access match 1 million by May 2025. We've got one of those beautiful geometric flowers made of pills in the middle, saying million match for HypCare on top of it. The HypCare logo is a goopy light gray H on top of a navy blue pill with HypCare written in pink. And on this slide, we've got a QR code as well, where you can contribute to this campaign. And that will also show up in other places in this presentation if you miss it this time and would like to contribute. All right, next slide now. Asking this question for folks to start dreaming. What if there was a place you could go that provided treatments based on symptom experiences instead of narrow diagnostic criteria? What if there were robust care options available for every manifestation of the Hyp constellation, all in one place, and those care teams worked together as teams? Just something to think about. And on this slide, we've got a few more of those geometric flowers floating off into the bend of pink. All right, next slide now. So that's what we're doing. Hyp+Access is launching a groundbreaking New York City-based medical and alternative care program. This is the first of its kind. It's a modular system of affordable, integrated clinical and alternative care options by and for people with connective tissue-related disorders or disabilities and overlapping conditions, including and especially long COVID. So we'll talk more about HypCare later, but it's very important, it's very vital, it's very urgent, and that's why we're here today. And we've got our HypCare logo again on this slide. I'm going to go to the next one now. We're going to talk about today's topic. What is Hyp? Connective tissue variance, multi-system, multi-system. Excuse me, there's a typo on this slide. It should be multi-symptom, multi-system, or multi-system, multi-symptom. But that's what that is. And that's what we're here today to chat about. And Hyp is this huge constellation, and we're going to get into everything it includes and how that relates to connective tissue. All right, next slide now. So Hyp is an umbrella term, and we're going to talk about what it means and why we use it. So manifestations of widespread connective tissue differences are vast and varied. It's a constellation of hyp-er, or above the norm, and hyp-o, or below the norm, body states that may or may not be medically recognized through diagnosis. So the way we define Hyp and use this term, it's a catch-all term for connective tissue-related conditions and disabilities and the people who experience them. So some example usage of the term Hyp is Hyp conditions, I am Hyp, I'm a Hyp, or we are Hyps. So noun or descriptor. We try to use it for all kinds of things to talk about. I'm going to go to the next slide now. The fluctuating extremes that make up this constellation. So we consider Hyp and connective tissue a constellation because of everything it includes. So we've got some words popping up on this slide that I'm going to read that should demonstrate that. So sure, we've got hypermobility, which people are hearing a lot about, and hypomobility, or decreased mobility. We've got hyperthyroidism, hypothyroidism, hyperpermeability. That's a really important one we're going to talk a little bit more about later. Hypopermeability, hypovolemia, or low blood volume, hypoadrenergic, hyperadrenergic, hypotension, hypertension, and this goes on and on and on. These are words that medicine or just language in general has developed to describe extremes. And extremes are certainly something that happens when we have impacted connective tissue. All right, I'm going to go to the next slide now. So we want to lead with who is affected, because this is a very deep crisis and something that has been neglected for so long. So to lead with prevalence, or how common something is, we say about 1 in 5 are on the connective tissue variance spectrum, but this is a very conservative estimate based only on available joint mobility data on select joints. So it's a lot of people. 1 in 5 would be 20% of the population, right? But it is probably more than that, is all I'm trying to say. So very importantly, COVID exponentially is increasing prevalence and severity of all the diagnoses that we're going to cover in this teach-in. And then if we get into folks that this is more common in, or demographics, we're talking people born with uteruses, people of color, or the global majority. But very importantly, most people diagnosed are white affluent people. So we've got huge disparities occurring. This is also a lot more common in trans and gender nonconforming people, and autistic and other neurodivergent people. And we have some citations at the bottom there. And as a reminder, we're going to share all those citations on our website for people to have easy access. All right, next slide. So to talk about how the medical system treats hypes, spoiler alert, it is a bad situation. Medicine separates symptoms into extremely specialized medical categories, isolating information and even intra-system problems, so problems that are really occurring within one body system, rather than integrating all of that by way of connective tissue changes and repercussions. So it's not thinking systemically, it's not thinking connective tissue, it's putting all these symptoms in really specialized, really separate categories. And to do this, it relies on limited so-called objective measurements, things like blood tests and point-based diagnostic criteria, rather than what medicine considers subjective symptoms or impact on quality of life. And this means that so many people are left with zero care because those so-called subjective measures are not based on large data, and they don't include undiagnosed populations who actually are more impacted because of the types of disparities that we look at in demographics and the medical system itself. So this really reduces the, yeah.
Can I add something? I realized when I rewrote that I didn't quite write it the way I wanted to. I
Please.
meant to say that both subjective and objective measures are not based on large-scale data, nor do they include undiagnosed populations. Not just the subjective measures, but really very much the objective ones as well. They're very just kind of, oh, let's throw this thing at it and see if we can find something. And then that's often how they arise rather than large-scale population data. I end there.
Totally. Yeah, it's a lot of experts deciding what criteria should be rather than actually collecting a lot of information, especially from marginalized populations who are left out of data anyway. Yeah, so all of this really minimizes the lived experience of hypes or people with connective tissue variants, and too often fails us in the diagnostic process, whether that's misdiagnosis, not getting diagnosed at all kinds of things that we'll talk a little bit about later. So this is really important. We at Hyp+Access view diagnoses as insurance-based requirements of accessing medical care, rather than accurate accurate descriptions of biological processes. So we do not view diagnoses as truth. Diagnosis is not objective truth. It's how people end up being categorized within a system. Another way to talk about that is pathologization, which is a process where usually medicine is deciding kind of what is, in air quotes, wrong with someone, what is the reason why they're experiencing what they're experiencing. And that drives the diagnostic system in general, but is not necessarily accurate to people's experiences and certainly not conducive to meeting their needs. Is there anything you wanted to add about pathologization, Audrey? Because I know you popped that in there. Good. All right. We'll go to the next one. All right. So now we're going to launch into actually listing and going through a lot of the diagnoses we're actually talking about here. What makes up this constellation, which is just so many different things. And we're going to start with what is usually categorized as musculoskeletal diagnoses, but sometimes considered genetic or other specialties. And I am actually going to read out everything that's on these slides, but I'm going to try not to give too much narrative on them. So in this category, we've got fibromyalgia, complex regional pain syndrome, benign joint hypermobility syndrome, hypermobility spectrum disorder, hypermobile Ehlers-Danlos syndrome. Then in the category of viral, bacterial, environmental exposure diagnoses, we've got myalgic encephalomyelitis or chronic fatigue syndrome. We've got long COVID. We've got chronic Lyme. We've got multiple chemical sensitivity. And a reminder that all of these diagnostic lists right here are not exhaustive. It would be impossible to be, because the medical system has developed so many different diagnoses for what is, from our perspective, one constellation, stuff that has to do with connective tissue. All right, next list. So under allergy immunology diagnoses, we've got mast cell activation syndrome, hives and chronic spontaneous urticaria, chronic eczema, asthma, Crohn's disease, primary and secondary immunodeficiencies. Under rheumatological, we've got Sjogren's, lupus, Hashimoto's, polymyositis, mixed connective tissue disease, if anyone's gotten that one, rheumatoid arthritis, ankylosing spondylitis. And then we've also added under endocrine, hypo and hyperthyroidism, and diabetes is actually related. Right? Gonna keep going. Under the gastrointestinal category, we've got slowed digestion or motility issues, gastroparesis, small intestinal bacterial overgrowth or SIBO, irritable bowel syndrome, IBS-D. Then under cardiovascular, we've got the classic POTS, postural orthostatic tachycardia syndrome, as well as other forms of dysautonomia or syncope, which is fainting. We've got median arcuate ligament syndrome or MALS. We've got aneurysm, flow murmur, mitral valve prolapse, aortic dissection. And these lists go on and on. I'm going to go to the next one. All right. And you can see that this is spanning, all the systems of the body that are supposedly separate, right? We've got under urogenital, vulvodynia, priapism, which is painful erections, incontinence, interstitial cystitis, pelvic organ prolapse, polycystic ovary syndrome, endometriosis. And now we've got a big list of neurological diagnoses, headache and migraine, cerebrospinal fluid leaks, Chiari malformation, cervical medullary syndrome, spontaneous intracranial hypotension, idiopathic intracranial hypertension, tethered cord syndrome, syringomyelia and hydromyelia, trigeminal neuralgia, nerve compression, and small fiber neuropathy. not exhaustive. And going on to even more lists, we've got the huge neurodivergent overlap with connective tissue variance. So in this list, we have anxiety and depression that folks get diagnosed with a lot, autism, ADHD, bipolar, borderline personality disorder, eating disorders, OCD, Tourette syndrome, dissociative identity disorder, schizophrenia, and other schizoid disorders, or diagnoses to be more accurate, complex post-traumatic stress disorder, and post-traumatic stress disorder. And this is not exhaustive. I'm going to go on to, I think, the final list, which is psychosomatic diagnoses. So these are diagnoses that are used to generally write off problems and dismiss folks and do other forms of violence to them as well. So in this list, we've got hysteria, which folks aren't quite diagnosed with that name anymore, but many other names that actually grow out from that same history. And in that oeuvre, we've got conversion disorder, somatization disorder, psychogenic non-epileptic seizures, or PNES, functional neurological disorder, factitious disorder, which basically means someone's lying, or that's what the doctors think. So this is a huge form of violence that the community faces. Hypes are frequently psychiatrized, characterizing their symptoms as coming from an unknown origin or being stress transformed rather than being physiological. And I want to kind of wrap up this section by saying any diagnosis someone has received that felt validating to them or that helps them navigate the world, there is nothing wrong with that. This is not about how people personally identify. This is about how the system is categorizing folks and the different forms of either care or neglect or violence that those diagnoses lead to for them. Right? Go to the next slide. So we're going to compare some diagnostic and symptom criteria for these two of these supposedly separate diagnoses. We have the abbreviation SX at the top, that means symptom. So this is just one example pulling together criteria that shows up in diagnostics for fibromyalgia and myalgic encephalomyelitis, chronic fatigue syndrome. So I'm going to read through what we've got for fibromyalgia, which is widespread pain using a specific index with 17 areas of possible pain. We've got a symptom severity scale that's used that looks at fatigue, waking unrefreshed from sleep, cognitive symptoms, somatic symptoms, or physical body symptoms. Then we've got gastrointestinal symptoms showing up. We've got criteria like experiencing these things for at least 3 months. There is a new test, an FMA test, that measures cytokines in blood, which is an indicator of mast cell activation. Audrey, is there anything you wanted to say about that one?
This is Audrey speaking. I just added this because it feels like we're constantly chasing our tails in the same circles in these different diagnostic groups where, oh, all of a sudden, maybe cytokines are involved and there's systemic inflammation coming from mast cells. Aha, and this is just a new and another example of that when even in mast cell activation syndrome diagnostics, cytokine measurements are not proven to be correlated to symptom severity or indicators of disorder presence. And so, anyway, we're just kind of going in these circles and it feels like we're not talking to each other. And none of these diagnostic measures really encapsulate the majority of the even diagnosed population. It tends to only be between like 30 and 40%. And so that is all. Yeah.
Yeah. Yeah, and that's not to say that things with cytokines aren't going on. Of course they are when mast cells and connective tissue are impacted, and we'll look at that in just a bit. But because of how separated all these research fields are and the diagnoses are, you've got folks or researchers really going down certain rabbit holes and trying to come up with more narrow criteria to, really solidify what that diagnosis is rather than looking at the overlaps. So for the overlaps, to talk about ME/CFS criteria, we've got something called post-exertional malaise, or PEM, which has so much overlap with the different kinds of fatigue experienced by other hype diagnoses, but is kind of categorized and thought about in a specific way within the ME field. We've got unrefreshing sleep, like we do in fibromyalgia, cognitive impairment, like we do in fibromyalgia, and or orthostatic intolerance or dysautonomia, which overlaps with a whole bunch of other hype diagnoses. Then we've got gastrointestinal symptoms like we did with fibromyalgia. We've got chemical sensitivities, which has huge crossover with mast cell conditions or diagnoses. And we've got that same criteria of having experienced this for a certain amount of time, at least 6 months for ME. And it's worth noting that both these diagnoses, part of the criteria is there being an absence of what they call obvious tissue damage. And that is the same with hypermobility disorders or hypermobility diagnoses. They try to rule out there being some obvious cause of tissue damage. Of course, they aren't really looking at tissue in the way they would need to, but that's another discussion. All right, I'm going to go to the next slide to bring up this big sentence we have written across another navy and pink gradient. We find that there is variation between hype individuals, but no clear distinction between most hype diagnoses in terms of predicting severity, the number of systems that are impacted, the need for comprehensive multi-system care, and the treatment options that improve quality of life. So we actually see the same needs and the same things happening across these diagnoses with no clear reason other than certain social and economic factors why people end up in one category versus another. All right, next slide. So we want to talk about treatments as well to drive this point home a little further. These are lists of treatments that work and don't work across different diagnostic pools or populations. And this is not, true for everybody. This is sometimes they can work, sometimes they can hurt. But again, we see the same things working and hurting no matter what diagnostic category people end up in. So to list out things that can work for folks or can be really impactful for quality of life, we've got saline infusions, which can be really hard to access. We've got low-dose naltrexone, ketamine, midodrine, mestinon, avoiding histamine-rich foods, Zofran, antihistamines and mast cell stabilizers, non-targeted epidural blood patches, cannabis, and many, many more. It's not that there aren't treatments out there, but because diagnoses are so separate, a lot of folks don't have the breadth of information about what might be able to help them. And instead, what they often end up getting are things that can be incredibly harmful. At the top of that list for a lot of folks is physical therapy. We've also got cognitive behavioral therapy and generally pretending that things aren't as bad as they are, or folks being pressured to do that. We've got folks getting no treatment aside from psychological treatment, no pain management, things like psych meds for pain, antidepressants, SSRIs, which can be helpful for some folks, but can really, really harm others. We've got things like nerve blocks, which can sometimes further destabilize a physical situation someone has going on. And we've got surgical intervention. And the healing for that is really a coin toss. The outcomes are quite unpredictable and not really what you want to see. And again, sometimes really helps certain people, but we also see a lot of harm occurring. And a lot of these interventions have much, much higher risk profiles than so many of the things on the left side of the slide that have much lower risk profiles and a lot of folks just don't have access to or information about. All right, going to the next slide.
I
So
think
just
this
to talk,
might be me.
Audrey, what?
This might be me.
Oh, are you supposed to take over now?
It is. Yes.
Go
The
for it, babe. All
final.
right,
Sorry.
you're fine.
This is Audrey speaking. And now we're going to get into the science a little bit, but I'm going to try not to go too much into a hole. Um, so we really want to talk about, and something that we've talked about for a really long time, although sometimes it takes a while to maybe go through all of what we bring up, is the problem with the focus on hypermobility in connective tissue diagnostics. So hypermobility is a term describing kind of abnormally large range of motion in select joints. The way that it's measured is very select joints. Um, it's measured through the Baton score is right now the score that is currently used, although all of the scores that were used before the Baton score are precursors of the Baton score. So it's all kind of the same thing, just over some decades. Um, it's really the main medical identification method used for diagnosing connective tissue disorders that acknowledge the connective tissue mechanism. The diagnosis examples we're going to give are hypermobile Ehlers-Danlos syndrome and hypermobility spectrum disorders. And oftentimes what we see, actually all the time, is that HEDS and HSD are actually the same thing, and the Baton score does not categorize people by severity or impact. It literally only measures jointed motion, supposedly, although there's many situations where clinicians are not doing it the same or have stricter ideas of what it means. And overall, there's a just wealth of research that's continuously coming out disproving it as a useful diagnostic tool or severity indicator. So this focus on hypermobile joints as this aesthetic main measure that someone has to have, what we see happen time and time again is it's used as a tool to deny care, especially multi-system care. So the care for GI symptoms, for really bad fatigue, for really bad neurological complications. Yeah, it's not good. Um, and really to us, a lot of these diagnoses end up being arbitrary because it's all connective tissue variance. And that may seem like a really big statement to make, but we'll get into what connective tissue is, and then it starts to be maybe become clear why there's so much variation and why it changes across the lifespan. So, from our perspective, listening to and believing in people's pain, illness, and other symptom experiences are really the primary focus and really the only way to include everyone in diagnostics and care. And we'll talk a little bit more about why sensory information is actually the most pertinent information we can be using. You can go to the next slide, Elle. Thank you. So this is a meme that we recently posted that kind of landed, although we're going to explain it a little bit more. So it's this Spider-Man meme where there's 1, 2, 3, 4, 5, 6, 7, 7 spider people in their costumes pointing at each other in a circle, like kind of like, oh no, but it's you. Oh no, but it's you. And on top of each of the spider people is a different diagnosis that we talked about earlier. So from the left to right, top to bottom, we have IBS, fibromyalgia, ME/CFS, POTS, and then on the bottom, long COVID, HEDS/HSD, and endometriosis. And then at the bottom of the meme, there's a asterisk and it says, and many, many more. So on the left of the screen, there's a line that says, in quotations, comorbidities or co-occurring distinct conditions, and we've crossed that out. And on the right bottom of the slide, we have text that is not crossed out, saying manifestations of connective tissue variance, one interconnected hyper-hypo constellation that changes throughout life. So this meme was supposed to kind of be like, who knows what my symptom is coming from? But maybe because all of these things are kind of the same thing in different forms or different body systems or showing up in different ways with different triggers. Anyway, we go to the next slide. So now we're on a slide that has that really rich, deep gradient on the background of the navy to the pink and text that reads, narrow and hyper-specialized diagnoses separate us from each other and often from care we all need access to. We must embrace the connections between our multi-symptom, multi-system, we got it right this time, experiences to build a future full of care that leaves no one behind. And that's really important to us. We can go to the next slide. So to talk more about what causes or maybe worsens hype experiences, um, we're talking about multi-system, multi-body system. All of these body systems usually have multiple symptoms related to their dysfunction or these manifestations of connective tissue that is impacted throughout the body. It comes from complex genetics. There's a huge genetic focus, especially in hypermobile diagnostic research. Well, in all research, but especially there because genetics was founded on hypermobile genes. Hint, hint. Um, we know that this comes from what is called mosaicism, which means it's many, 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 many different genes combining. It will never be one point mutation. And the race for that is kind of a ridiculous use of financial resources, in our opinion. It also comes from environmental toxicity or exposure. So being exposed over generations to environmental toxins, which maybe could start to explain why certain demographics are more impacted. Malnourishment, viral or bacterial infection, acute or chronic physical impact, and many more. So it's really this combination of nature and nurture where it has to do maybe with some genetic risk factors, though maybe not for everybody. And then over time, it really relates to, the levels of oppression that people are experiencing and their access to resources. Okay, we go to the next slide. So connective tissues connect the issues. We have an image here of areolar connective tissue by one of our community members, Rafi Daro. And it is an image with a bunch of different cell types together as making up connective tissue. There's fibers running through it in a really dark navy, maybe. We've got some pink mast cells. We've got some purple fibroblasts. The nuclei are darker colors. And then there's some lighter pink and blue kind of swaths of tissue, visually kind of denoting different layers of the connective tissue and how it all relates together in a three-dimensional space. We're going to go to the next slide. Connective tissue is really what most of the body is made up of, and we do not exaggerate when we say that. It is not just fascia. Also, there's many different types of fascia. So the idea that there's one type of fascia, throw that out the window. Many, many types of fascia. It also includes bone, blood, the lymph system, fat, and the endocrine system, ligaments, tendons, cartilage. From our perspective, it's everything except muscle fibers and nerve cells. And every single muscle fiber and every single nerve cell is actually wrapped in its own layer of connective tissue. And so connective tissue literally is throughout the body and organizes systems on a cellular to a macro system full body level. Um, the other thing that's really, well, actually, let me go back. So sometimes people will say epithelial tissue is a different type of tissue. And to us, epithelial tissue is really just a specific type of barrier membrane cell type. And it really acts very similarly as connective tissue, and it actually, the connective tissues below it often actually kind of not control, but really influence how the epithelial tissue is changing. So it doesn't really feel like a separate system to us. Um,
Audrey,
yes.
jumping in, if you could just tell folks what that type of tissue is,
Epithelial,
lining organs.
yes, it lines organs and mucosal membranes. usually like the outermost layer of some type of system or some part of system that's interfacing with another system. Um, and the connective tissue below that tissue, it's usually like a single cell layer. Sometimes it's multiple cell layers, but oftentimes it's one. And it's really a highly specialized form of barrier function in terms of the barrier that decides, oh, this does get through, or oh, this doesn't get through to the tissues below. Um, the other thing that's superbly important that everyone should know and all clinicians should be taught and all anatomists should be aware of is that the sensory receptors that regulate literally every single one of our organ systems are exclusively housed in connective tissue. And so the what we sense in our daily lives as sensation of our environment and what's happening in our body, those are the exact same receptors that all of our body systems use to regulate themselves, which means to us that your sensory experience and information is actually the most accurate form of internal information that we have access to. Because without those exact same receptors regulating all of our systems, including our conscious process and how we then navigate the world, how would you know when you are in pain? So anyway, sensation is really what tells everything to work, whether or not we are consciously feeling it or not. And we really, our experience with clients is that everybody tends to know exactly what's happening in their body and they voice it in some way very early on. And then that gets kind of, pushed out of their personal validating process. Um, So then a question I have here is, what happens when we stretch past sensory reception or like when our connective tissues get into a state where that sensory feedback is not actually providing our systems what it is expecting or maybe needing to regulate accurately. So overall, connective tissue is really endless forms and textures. It organizes the entire body from literal single cells to organ systems, to how the body communicates across cell types, how it processes sensation and coordinates movement. When we talk about connective tissue, it's so many things. Um, and that's why we get so effed up, you know? Um, so going back to this image of Rafi's illustration of areolar connective tissue. Areolar connective tissue is the most abundant form of tissue in the body. It's this really goopy, it's often what people actually think of as fascia, to be completely honest. But it's a combination of water, of fat cells, of fascia. It's really all integrated together, and immune cells like mast cells and fibroblasts. And mast cells are actually a connective tissue cell type. They're finally being acknowledged as an immune cell right now. I would say 3 years ago, Johns Hopkins did not say that on their website. But they are a connective tissue cell, and so are fibroblasts. And mast cells, you may have heard of before, they, explode essentially in response to environmental changes in their external milieu, is what it's called, but it's really just like the goopy stuff that's floating around it. And they are the initiator of every single immune and inflammation response in the body. Literally all of them. It goes back to the mast cell. They initiate cancer. They initiate so many different things, tissue degradation, tissue growth. They're master cells. That's why they're called mast cells. And then fibroblasts are these really fun cells that are technically immune cells, but what they do is they grab on to a bunch of collagen fiber within the connective tissue matrix. And basically, in response to changes in their environment, they tighten up and pull the fibers together and they let go and they let the fibers be a little looser. And so, even though they are very much described as an immune cell, they have very, very, very important, um, not musculoskeletal, like structural properties that change the consistency of connective tissue in real time. So it's a whole lot of stuff, And then when we think about all of these diagnoses that are diagnosing, oh, the pain component, or the mast cell component, or the chemical sensitivity component, or the autonomic dysfunction component, or whatever it is, all of these cell types exist together in the same goop. So, you know, anyway, mediates a lot of processes, is all to say. And we'll go to the next slide. This is an image we haven't released yet, so you're the first ones who are seeing this. It's another one by Rafi. It's actually an SEM image, which is a very specific type of like micrograph image of really, really zoomed in tissue types. So this is dense, irregular connective tissue. It includes collagen. It doesn't have as much of that water and fat in it. It's really more of a fibrous tissue type that provides structural support to withstand force, but it's not linear. It kind of has this like wild, like spirally sense to it, kind of to support all of these different directions that it maybe is in relation to. Um, Immune cells like fibroblasts are also embedded throughout and they also produce and maintain the fibers in the matrix. So fibroblasts are actually very similar to stem cells. They're the only other type of regenerating cell type in the body. I don't know how you want to think about that, but you know. And so a question we have here is, how would you think about immune-related inflammation impacting fibrous tissues over time? And an example that Al gave was adhesions of organs attaching to each other, or, different types of mobility then impacting the way that tissue is being directed to be built within these structures.
Mhm. Yeah, and before I go to the next slide, I'll give a quick image description of
Oh,
this
sorry.
beautiful illustration. We've got greens and deep dark purples and bright light yellows, all swirling together in tangles of kind of fibrous spirals, kind of coming in from the center, extending out towards the edges, and all kind of different types of asymmetrical curves and mm, I won't
So
say tangles, spirals, swirls. It's a very beautiful image and you can kind of see how 3D this is, how all these different fibers cross over each other and take up that three-dimensional space to grow and to connect different things to each other. Yeah. All right, next slide.
So, what happens when connective tissues become more hype? And there's a lot of roads we could go down, and this is not an exhaustive list, but we're going to go down a few roads. Um, One of the things that we think needs to be talked about more is that when mast cells and other immune cells are more easily activated, or when those tissues may not already be super stable, whether that is shown in the joints or not. You really don't have to have jointed mobility in order to experience a lot of these repercussions on a more cellular level. Um, it actually increases the permeability of those tissue layers and protective membranes, including epithelial tissue. So what that means is things get through more easily. Cells within the tissue layers are more easily triggered by chemicals or different things entering the cell environment. And that's also how many things get through the blood-brain barrier. And so a lot of barriers that in our body are supposed to keep certain viruses of size out above a certain kilodalton size is usually the what they're measuring. Those things end up getting into closer layers of organ systems and tissues that are much more sensitive to external, factors coming in, which may explain post-viral illness to a certain degree, or at least that kind of constant loop. It's kind of a little bit of a chicken and egg scenario, like what came first, the connective tissue variance or the viral infection? And sometimes it's not really worth trying to decide. Um, Then tissues degrade really from a cellular to systemic level. One example of a more cellular you may have heard of are fibrin microclots, which is a theory of long COVID. It's actually been a theory for a very long time. Some people think that this recently came out this year. This was actually introduced in early 2020 by people who were working on fibrin microclots kind of before long COVID like came onto the scene. And these are really tiny, actually kind of misfolded pieces of connective tissue, of essentially kind of fascia. And they float through the bloodstream. And because they're so tiny, they actually end up clogging microvasculature, which is a theory of how, even though blood is flowing in someone with long COVID or post-viral illness or whatever diagnosis they have, that oxygenation to tissues just doesn't quite happen. And people still feel really like, I'm not getting the oxygen because it's just not getting to the ends. A more systemic level example of tissue degradation is thinning or tearing of fibrous connective tissue, like the connective tissue we just saw with the green spirals. That can start to kind of snap and thin in a certain way, and make things just generally more unstable or permeable. And in response to that, tissues thicken. So, like Elle's earlier example of adhesions of organ systems in response to certain permeability changes, um, that can really happen anywhere. So we can get thickening in an area where there is more joint mobility. We can get thickening in an area where there's less joint mobility. Muscles also tense in response, and that has to do with our spinal circuits and that sensory feedback that we were talking about, how those receptors are in only connective tissue. And then I added substance P, which is really what initiates the pain signals in our nervous system. And so when all of these things happen, a lot more substance P is created, and we go, ouch, that hurts. And then we get into this place of chronic feedback loops where it's not the kind of normal expected, oh, this thing happens and then the body kind of resolves it over time. It's like, oh, we're stuck in this loop. We're kind of spiraling around this drain, you know? And an example of that is injured tissue and untreated pain. And oftentimes, well, no, across species, when pain is present in a muscle, there are changes in the spinal circuits that actually change the way the muscle activation is being distributed and the way that movement is occurring. And a part of that is hugely adaptive, probably to try not to create more pain. But then what we end up often experiencing when we have these chronic issues is muscle spasticity, where those muscles are just really, really tight in some places and they just will not let go. And then that causes lack of oxygen or hypoxia from reduced circulation and mast cell inflammation from that tightening and maybe from that degradation, whatever's happening in those joints or kind of that area of the body. And then we're kind of in this space or this general, what is it called? Like our starting point, our baseline becomes chronic tissue vulnerability and degradation to further acute changes. So we're in this loop where then something else might be introduced and it might start to make it worse. And it can kind of enter at all of these different points. We can go to the next slide. Um, in regards to hype and long COVID, although we kind of see them as similar versions of the same thing. There's a huge overlap in diagnoses and mechanisms, structural connective tissue damage, and a chronic hyperinflammatory state on both cellular and systemic levels, causing multi-system problems that are also found in all of these hype diagnoses in different ways. A lot of people are being diagnosed with these exact same ones. I'll mention POTS. There's a big push in association with ME, and that makes a lot of sense. There's also actually a higher percentage of people diagnosed with POTS after COVID infection. And so this is just kind of an example of why all of these diagnoses need to be included and talked about and really pushed to get care access because it's not just one. And anyway, yes. Um, we know that COVID infections can cause or worsen hype conditions. Specifically, there's been research coming on that. Long COVID is considered a post-viral syndrome now. And when COVID hit, we knew what was about to happen. And from the beginning of the pandemic, we're pretty concerned because we knew what the state of care access was for all of these conditions and how horrible it was. And, that, oh, well, physical therapy is going to be introduced and it's going to be pushed to do all of these things instead of actually looking at the physiology behind it. It's going to be kind of pushed into this, it's all in your head situation. And academic research is just catching up now, we would say, in 2024. Um, and COVID research has actually really helped understand the physiology behind a lot of these other diagnoses as well. So I think there's a positive, silver lining in a certain way. Um, in terms of prevalence, COVID has exponentially increased the population in need of this kind of care. There's about 400 million people globally currently or previously having lived with long COVID, and that's just long COVID, right? So if we think about that 1 in 5 and then 400 million, there's definitely a lot of overlap between those two populations, those two prevalence populations. And at the same time, we're talking about, huge swaths of people having some of these experiences at some point in their life. Go to the next slide. Um, from our experience tracking these medical systems across cities, states, across the country, across countries, um, there's really no comprehensive care available anywhere at any price point. Really doesn't matter how wealthy you are. Of course, people with a lot more wealth can try a lot more things, but we've never really seen different outcomes. Um, we know that there are hundreds of millions of people without access to quality of life care and who are often drained of any financial stability due to higher healthcare costs because they're just trying to figure out what might help them. And they're having to ask a lot of people because the systems are all broken, including, single payer health systems. I wish we had that conversation with more nuance because the systems in Canada and the UK are really, really produce the same problems in different ways. Um, Clinicians are overworked and poorly treated due to their advocacy for patients. We see clinicians just disappear all the time. They get really overwhelmed. They can't handle it. They're not being given the support on an infrastructural or systemic level, and they just kind of throw up their hands and they're like, I can't do it anymore. And then all of these people just don't have a clinician. Um, so, from our perspective, current health systems are unable to provide the long-term solutions necessary to really tackle this public health crisis at scale and often punish and harm people for seeking appropriate care, especially if they're from communities that are generally, um, you know, uh, more impacted by the medical system and other systems. We can go to the next slide. So what we kind of see starting to happen is different diagnostic communities are kind of pitted against each other, whether it's intentional or not, and whether people are really like aware of that happening. Um, we see all of these different subcategories of what we really view as the same thing in different manifestations across specialties. So many different clinicians come in and, oh, this is my theory, and it's kind of like, wait, like where have you been? Like why do you think you can decide that? And it really divides communities who experience similar things and respond well to similar quality of life treatments. And so then we get the situation where, oh, we need a third stage clinical trial before we can use this medication off label in this population. No, we don't really need that. There's ways for insurance to cover it without that third stage clinical trial, without that necessary like FDA approval. Of course, there's regulatory conversations around that, but a lot of the medications and interventions we're talking about are quite low risk compared to a lot of interventions that are consistently pushed on these populations, and kind of how these populations are actually taken advantage of by medical science to push experimental brain surgeries or, whatever it is. So, anyway, from our perspective, our current medical system is very dangerous for hypes, particularly for people more impacted by systemic oppression, folks who face barriers and bias due to economic status, race, size, psych history, and more are often just fully flat out denied care and frequently harmed via involuntary institutionalization, which is kind of being placed in involuntary hold in like a psych ward, and other forms of violence, including other forms of incarceration. The discrepancy we see between certain clients compared to others is just stark within seconds. It's not in exaggeration. The medical system overall is really bad for everyone. Nobody gets anything good out of it. Everyone comes out of it with significant trauma at whatever price point you're paying for it at. And no level of privilege is really protecting folks from these problems of care. And what we observe happen is it really strengthens the dynamic of avoidance and weaponization of privilege in chronic illness communities. And so we're fighting over crumbs rather than advocating for complete shifts in care and complete shifts in the way that the system is functioning. And when we fight over crumbs, we push people out, we harm people who are more marginalized, and we do not acknowledge how what change really has to happen. And we also really validate the systems of power that are already in place without questioning them.
Mhm.
And we need to
And
question.
I wanna add, in case anyone needs an example of something we're talking about here, an example of fighting over crumbs would be folks who, maybe they have a certain level of privilege, but the care they've experienced has been terrible. They got a diagnosis like hypermobile EDS, and that really validated them. And they want to believe what the establishment is saying, trying to keep that criteria really narrow so that fewer people are able to access those specialty physicians that are already so difficult to see, rather than realizing the scale of care neglect and that so many more people than have that diagnosis need that kind of care. All right,
Thank you.
next slide.
So, I mean, I think probably everyone agrees, but it's really not an exaggeration that lives are on the line. They've been on the line since before COVID. They're on the line now. And we really believe that it's time for communities with different diagnoses to come together and fight for quality of life care for all, which is really one of our goals with Hyp Care. But we'll get into more of that maybe later.
Yeah. All right. So I'm going to describe the slide we're looking at now before we take our little break. Of course, it's us, so we're running late. But we're going to take a 5-minute break and then have some time for questions and talk about Hyp Care. So the slide we're looking at now that we'll leave up during our break says at the top, support the Million Match campaign. Everything helps. We're not kidding. Everything helps. And everything is doubled in impact because of our anonymous angel donor matching the first million we raise. So we've got a link here, givebutter.com/mm for Hyp Care. And we've got our geometric flower with the million match for Hyp Care, these green and lavender flowers. We've got a QR code that you can scan. And we're going to talk more about Hyp Care after our break, after we also let you ask some questions. So I'm going to pause our recording now. We're going to take a 5-minute break, and then we will reconvene to chat together. All right.
So if we come back at 20 past the hour.
Yes.
Okay. And if folks have questions they want to add in the chat now, welcome to do that. We will gather them accordingly, but also it's cool if not.
Yes. And I think, hang on. I accidentally stopped my screen share when I
I
want
think it is
to
actually
pause.
recording.
Yeah, I paused the wrong thing. All right, now I'm pausing the recording. All right, this is Elle speaking. We're back from our break and are going to have some time for questions. I'm going to stop my share. And folks can feel free to ask questions in the chat, which we will read aloud, or unmute themselves to ask anything they would like, if anyone has questions. No, we threw a lot of information at you, as we always do.
Hello. Can y'all hear me?
Yes.
Hi, this is Alice. I was wondering if there are any models in other parts of medicine or in other places where you found kind of this integrative care approach was more successful, things you're trying to kind of model your plans off of? Like, what would be something ideal that you can look towards? Or not perfectly ideal, obviously, but that kind of angle.
Yeah, thank you, Alice, for the question. Um, Also, I think I know which Alice this is. So if it is, hello, good to have you here. Um, we have not seen any similar clinical models. However, um, there's an application called Something Good. No, that's not what it's called. It's called Stuff That Works. That's what it is. Stuff That Works. And it was a pretty early attempt at taking actually a lot of these um, diagnostic groups and having them submit information about what treatments were working for them and created really interesting um, data visuals around diagnostics and treatments. I'm not really sure what they really end up doing with the data. Or, people can, I think pretty sure you create a profile and you go in and you can see under your diagnosis things that people have submitted that have or haven't worked for them. And you can kind of see, like, I'm assuming, percentages of people that have had a good experience versus not. And they can submit different information around like what maybe negative symptoms they had. Um, but I think there's a big data opportunity here to think about symptoms and self-reported measures and maybe some objective measures and kind of look at them all within a group without the diagnoses as a defining factor and kind of seeing how they organize, if they organize differently. Um, so I would say there's patient-led initiatives that are maybe more related than clinical. So we'll see how it goes in the clinic.
Yeah, and this is Elle. I will add that a few components of what we have planned to do are semi-accomplished by a few things out there or approached by them. And one of those is like providing the types of treatments that we're going to provide. That can sometimes be accessible to the very wealthiest people through what we call concierge care. Some of these specialty clinics where people are paying entirely out of pocket thousands of dollars per appointment to get some of these treatments. But obviously, that's not accessible and that's not going to reach the vast majority of the Hyp population. And then I will also give a shout out to patient support groups and disabled and sick individuals who are actually sharing this type of information with each other. That is the basis of so much of the work that we come out of and the wisdom that goes into this model. Yeah.
Hi, friends. It's Adina.
Oh, hey,
Hey,
Dina.
Dina.
Hey, I have a few questions, so cut me off if it's too much. The first one is just an attribution question. I've started to write and use the phrase connective tissue variance quite a bit because it's so beautiful. And I feel that you all originated that term, and I wonder if I should be attributing it in my writing.
We often used to say connective tissue differences.
Mm-hmm.
And then we found Jessica, I'm not going to say her last name right, Eccles, Eccles. She's a researcher at Brighton in the UK. She was the first person who published. Well, is that true around connective tissue variants, or was it Tofts?
I'm not sure who first published. It's been a term that's been used in publishing a little more and has been connected to a certain extent to neurodivergence research. We want to
Mhm.
say, though, that be wary with Eccles research because Eccles has also collaborated with some folks who've done a lot of harm in this community, and we're not quite sure what those relationships are or what the trajectory of that research is. But proceed with caution whenever, psychosomatic things are being legitimized. But so it is a term that has been, we didn't make it up, is the moral of
Okay.
that story. We are framing it in a way that other people are not, in terms
Yeah.
of connective tissue, in terms of what that actually means, in terms of hype, and in terms of the people that are actually included in that constellation. Most folks that are publishing with that term are thinking really just probably HEDS, HSD, and maybe some neurodivergence.
Got it. That's really helpful. Thank you.
And
I'll
we
follow up with, I was going to send you something anyway for your approval. Go on, Audra. Sorry.
Oh, the last thing I was going to say was the reason that we transitioned from connective tissue differences to variance was because it was being published more frequently, and it annoyed us that we had talked about connective tissue differences for so long, and now it was being published as variance, which we just wanted to try and make it more like tangible within publishing, because there was such a clear moment when that transition happened. I would say it was a year ago, when they were publishing not around connective tissue disorders, but talking more about this general variance that encompassed these multiple things. Um, and there's something in the chat. Can you expand on the comment you made? Oh, okay. I'll get to this after Adina's questions. Thank you, Margarita, although it could be another person who's not named Margarita, but we'll get there in a moment. Adina, what was your other question?
Yeah, I just so appreciate really just taking in the levels of kind of systemic entanglement, the much more creative and expansive way that you're holding this. And I so thank you. Just two questions. Would you consider like strabismus, which is being cross-eyed, right? Or having tension in the back of the eye, and adhesions down kind of one side of the body, to be a variance of a hype condition?
Most definitely.
Uh-huh. Okay. Thank you. And I'd love it if you'd elaborate at some point, maybe not today because it's getting late, but on the treatments that you think are relevant. I'm aware of HAPT, but I'm curious about what else you're thinking about doing in your community care. Thank you.
Yeah, absolutely, Adina. And I will add on that last question that our flagship article, What is Hype, on our website does have a huge list of treatments already that you could check out.
Yeah. And I don't know if it's necessarily, I can't remember how many alternative care treatments we put in there. That's like a whole other realm of navigation of like, how is it safe? Is it not safe? Like something I spoke with actually Jess earlier today about was that a lot of hypes, their bodies change really quickly in response to different information. And some people think that means that their technique is working because it's changing really quickly. And that really fast change doesn't actually mean that it's safe or that it's stable or that it's going to support the person long term. So that's a word of caution when navigating somatic spaces.
Absolutely. And I will add one more thing on that topic, which is we are working really hard to try to release digital programs before the end of the year. And one of those programs will be a groundwork training in HAPT that will cover a whole bunch of that stuff, as well as some more kind of short trainings, deeper dives into connective tissue and some other things like neurology and sociological history of hype. All right.
Great. I
Let's
can't wait.
answer. Thank you,
So
Adina. You want to answer Jess's genetics question, Audrey?
I will. And then we have another Margarita with their hand raised. So we'll go to you next, Margarita, after this version of Margarita, who's actually Jess. So Jess asks, can you expand on the comment you made? Genetics was founded on hypermobile genes. Yeah. So this is research that Elle did. So I'm going to pass it to Elle, unless
Oh,
you through it.
no, absolutely. I couldn't read the question, so I didn't see that's what it was about. Yeah. So we also hope to release an old paper of mine that I wrote that dives more into this. It's also referenced in our blog post called Benign Asymptomatic Response. But essentially, there was a man called Victor McCusick He's called the founding father of medical genetics, and he built the entire field of medical genetics out of Johns Hopkins on hypermobile genes. And by hypermobile genes, we mean types of Ehlers-Danlos and other related connective tissue disorders that actually do have specific single point gene mutations. We're talking vascular Ehlers-Danlos, classical, et cetera. So Victor McCusick really kind of started out in the 50s and extended through until the turn of the century, building his career and the field of medical genetics off of those genes, and with the goal of being able to eradicate disease. That's really what that was about. This grows out of an older history of what's called eugenics, a movement focused on identifying certain, usually genetic factors to try to eliminate undesirable populations. This gets into white supremacy and racism. There's so much history to get into here. But this founding father of medical genetics, he built his career off those genes, and he really also wanted to find the hypermobile EDS gene. And they kept narrowing the diagnostic criteria for what that was, with the goal of identifying those things. He believed that the Human Genome Project around 2000 was going to be the key to find that, and it wasn't. They still haven't found it because it's way too complex. It's way too common. We've got this huge common constellation of connective tissue variants, disability, and illness. And the field of medical genetics really kept secret so much of that information about connective tissue, kept it within the field of genetics, really shut out a lot of other specialties because they were so elite and they got so much funding for research. So they kind of kept going down that rabbit hole and excluding populations with the goal of identifying genes. And you can still see that legacy alive today in his mentee, Claire Francomano, who's a big person with the Ehlers-Danlos Society, and in the general prioritization of funding for genetic research rather than treatment, rather than prevalence, rather than diagnostics. Excuse me, I meant demographics. Yeah.
And I think Maisie has their hand raised.
Yeah, thank you so much. First of all, thank you for all the information today and your time. I have two questions. I will do my best to be concise, though it is not my forte. The first one is, so I have a diagnosis of undifferentiated connective tissue disease after a lot of, well, there's something going on, but like we don't know. And I strongly suspect it might be hypermobile Ehlers-Danlos and also have like mast cell things. And after a lot of, I'm wondering if you have any recommendations as an alternative to chasing diagnoses and sometimes referrals around like, the idea that, oh, once I get to this provider or this type of provider, there will be more, possibilities, or there might be some more hope in that. And I'm wondering if you have any recommendations or advice around taking all that energy and agency and kind of where that energy might be better spent, especially with some of that information around those different treatment options, but also just in like ways of looking at, and then looking at it in ways of spending my time. And I imagine other people might have similar experiences, even if the like actual details are different. And along with that, the sort of second part of my question is, as someone who is like, my own experience, it is really hard for me to sometimes track what is or isn't making a difference. I also have ADHD, and like it just seems, and people are, there are sometimes where I'm like, okay, yes, when I drink coffee, this sort of thing happens, or this, but only sometimes. And I feel like I'm supposed to come into an appointment knowing what makes a difference, like what his, like this thing works, it doesn't work. I was on medication for a year, and I'm like, I don't think it's making a difference. Maybe it's like, and And I'm wondering if there's just infinite variables there. And some of the stuff I've learned from some of my friends, chronically ill friends, has to do with, how our bodies do process things differently. And so it might make sense that the things that other people are like, this does work or doesn't work, the absorption is different, or yeah, this is not concise, I apologize, but anything around like how to both trust the body, but also when there's these infinite factors, and if you're a person who menstruates, your hormones are all over the place all the time, and like what is coming from where, and any thoughts or advice you have on that kind of constellation of a question. I will stop talking now.
No, for sure. I'll answer the second and then maybe we can get to the first, Al. I don't know if you have a response to the second or the first more. But in terms of the second around how do you know, if we like to say, if you are unsure if it's working, it's not working. Like if it's not
I
making
love that.
a reasonable difference in your life at the time when you're supposed to be taking it, you have no information about whether or not it's working. The other way sometimes people figure out that something is working is they go off of it and then they feel way worse. So occasionally that does happen, especially with like certain antihistamines or maybe something that takes a while to build up in your system, like CBD or different kind of versions of cannabinoids, although that's not always the case. Um, and in relation to like what's happening in your body versus like your environment or like maybe the cycles your body is going through, sometimes being precious about it is like, who has fucking time? So like pick apart the pieces, and we really like to go by this idea of sensory intuition and that when you know, you will know, and it will make sense to you, and you will feel it in your body. And that's when you know. And if you don't know before then, that's fine. Because ultimately, you're literally dealing with so much information constantly and navigating life that, like, nobody could possibly figure that out in real time. And so, anyway, yeah, it's like this very, like, once you feel like you truly know, that's when you know. And anytime before that, coin toss. And I don't know
Yeah.
if you want to.
Yeah, I'll add just a little something to what I understood of the first part of the question, which was kind of where to put your energy, what diagnoses to seek, what doctors to see. And I feel like there something that can be useful is challenging what medicine has taught us to prioritize, which is the answer, the cure. Trying to get every correct diagnosis from any specialty physician with the hopes of that leading to something that can truly transform your life. I think that what can be a lot more impactful is focusing on whatever you have to do to secure specific treatments. A great example is cromolyn sodium oral solution is super impactful for a lot of people's gastrointestinal issues. You do not need to get every diagnosis that maybe you deserve to have or you've thought of getting in order to get access to that. Primary care physicians can sometimes prescribe it. Maybe they don't feel comfortable with that and they can refer you to someone you find on a Facebook support group for allergy immunology or gastrointestinal issues that can help prescribe that. Like focusing on the quality of life treatment that you think from your community research or from what you learned through us or others, that might have the kind of a big impact on your quality of life rather than trying to do it all at once and like focusing on what is the truth, what diagnosis, what condition do I really have, because it is all arbitrary. Focusing more on specific steps you can take to improve quality of life, whether that's specific medications or getting mobility aids or seeking out alternative therapies. And we don't quite have time to talk about alternative therapies and all the considerations around somatics and safety of physical therapy, but kind of letting go of the idea that you can get the correct diagnosis and get maybe a cure or transformative treatment from that, and focusing on really actionable steps and ways you can kind of game the system to get things that might really help you. And Audrey put that medication, bromelain sodium, gastrochrome, in the chat.
And that it's
Yes.
very expensive out of pocket. It's like $1,500 a month with no insurance. So it's one of these annoying medications. It was the first antihistamine they ever created because it's in liquid form and they never made it a pill form. And it is ridiculously not expensive to make, and it is ridiculously expensive. But that is pharma. And going back to the like sensory intuition piece around where to put your energy, like if you for some reason and don't really understand why feel like, oh, I want to pursue traditional Chinese medicine, great, do it. Like your body and intuition around how to navigate this is very likely going to get you to a much better outcome than listening to a bunch of people who are not existing in yourself. And so, you know, as much as you can practice trusting yourself, even if you don't know why and you don't have the language for it, that's really, really what we recommend because you are the holder of your sensory experience. And like we talked about, how those receptors are the same ones that regulate all of your body systems that allow you to sense the world. Like that is truly the most real form of information coming in your body that anybody has access to. And I know that's not what we're told at all, especially in relation to like cognitive neuroscience and kind of this idea that the brain controls blah, 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 you know, but no, no, we disagree.
Yeah. Indeed. And I think we should wrap up the Q&A for now and move on to a little hype care information for those who have time to stay. But if you have additional questions that we weren't able to answer, please pop them in the chat and we will save them for next time or for content that we create. Audrey, what you looking at?
Oh, sorry. This is just what I have to do when I look at my own, my eyesight is just getting much worse. Yeah, this will be a quick description of hype care too.
Yeah. We're just going to give you all some basic information about hype care since that is one of the reasons we are here today. So I will start sharing my screen again and we'll close out with the plans we have to change this situation. All right, I'm getting ready to share here. Boop, boop, boop. Share. All right. So this was our break slide, and now I'm going to move on. Oh, we did our Q&A, good for us. So repeating this question of what if there was a place you could go that provided treatments based on symptom experiences instead of narrow diagnostic criteria, all in one place. So that's what we are trying to do. Audrey?
Sidebar. One of the reasons that this is possible is because most things don't really have a diagnostic code that's like widely accepted across hospital systems. And so, in terms of insurance reimbursement, most clinicians who learn to treat these issues actually do it based on diagnostic or symptom codes rather than diagnostic codes. So, as much as the system is broken, it a little bit works in our favor here because a lot of times there isn't that code, and we actually have to use other codes to justify the treatment, even if someone does have that diagnosis. Anyway.
Which leads us to Hype Care. On this slide, we've got a big version of our Hype Care logo, which is a navy blue pill with a goopy light gray H and the words Hype Care in pink. Go on to the next slide. Is this you or me?
I think it's still me. Go through the end, I'm supposed
to. Okay, go for it.
So, you know, we did some patient advocacy and care coordination for a while. Even before we launched Hyp+Access, this is what we were doing in New York.
A lot, yeah.
A lot. And we really view ourselves as people scientists and socio-medical researchers. We're not really about like the academia coming in and telling us what to do. There's a huge escalation of community need with the pandemic. And we've really been responding to that as time has gone on. And seeing so many different clinics kind of rise and fall, you know, we get a lot of feedback from people about, oh, I went to this clinic and it was horrible, you know, and it's supposed to be by these people who do these amazing things and have this power. And it just felt like no one was actually really trying to redo the system. They were just really repeating the same problems over and over. So we really use care access and disability justice values to drive our infrastructure, although we are entering one of the most violent systems in the so-called United States. And so there's a lot of contradictions and tensions that we're going to be navigating constantly because we are really focusing on Medicaid access. But we got to flip it. We need to flip the system. So if you want to learn more about the Hyp care model, we do require a non-disclosure agreement just because we've had so many issues with IP in the past. And so anyway, we kind of have a group of people that have signed that and that we're going to be meeting with to talk more about and answer questions too. Go to the next slide. So we're actually opening our first doors in fall of 2025, which is really wild that it's happening. We're going to be absorbing our clinical leads patients who are facing an impending care gap, and then we'll be expanding from there. So we already have a location identified, our architectural plans are drawn, we've submitted our Department of Health application, we're contracting with insurance payers, and we have all of these databases that we've worked with that are really going to be informing our standards of practice as a whole. I'm going to go to the next slide. And our phase 1 services that we're launching with, and this is not, what Hyp care will only be, is care management. So we're going to actually have peers who will be doing really a lot of the heavy lifting and have kind of the lowest patient to individual ratio in terms of caseload. And they'll really be the person who navigates the whole thing with a patient, develops the really trustworthy relationship so that hopefully it's easier to tell that doctor, hey, you missed something, or hey, that wasn't the right response to give, because those conversations need to happen and they will be happening. We're going to be also offering non-interventional cardiology, pain management, primary care, infusion services. We're starting with alternative care that's covered by insurance because we are focusing on Medicaid access. So osteopathy and acupuncture will be some of the first alternative care methods that we'll be introducing, although there's definitely some room to bring in other kinds of alternative care through the coding of osteopathy and acupuncture, but that'll be for a later conversation. And then free peer programs. We'll have in-office services, but telehealth as often as possible. If you haven't already contacted your reps around the extension of telehealth for Medicare patients, please, please, please do that. If that does not happen and that is not renewed, it is going to cause the system to collapse so much more than it already is. So that's a really important thing. We'll go to the next slide. So we're looking for 2 to 5 million for this minimum viable product. The funding amount really will determine how we can roll out care delivery and how many people we can train pretty immediately to increase our capacities. We have a built-in training program in our care delivery model that is constantly ongoing. So just to say that. And there will be many bases covered, even if there are fewer clinician types initially, because we generally work with clinicians who serve many purposes as a stopgap measure for care needs. So even if we only have non-interventional cardiology and pain management, we'll be able to do mast cell management because we know how to code for them. And that's just what these doctors have done anyway. But then we'll, give everyone their reasonable load later on. Next slide. So, and this is more for like people who are connected to wealth, but we're not looking for mutual aid donations. We're actually very explicit that we don't want mutual aid funds that people are, saving and providing monthly. We're a nonprofit, and so we're looking for people who are interested in providing tax-deductible contributions. This could be minimum required distributions from Roth IRAs and other kinds of wealth building accounts. A lot of times people just reinvest that money into those IRAs, and we ask that you go to your family and you ask them, hey, where is that money going? And if they have a, let's say, $70,000 minimum contribution, which you don't have to have that much wealth in the scheme of billionaires in order to have that kind of minimum contribution, that you push them to donate all of it, yearly. Donor advised funds is another area we're looking for funding from. Other wealth strategies that include tax deductions. We actually take stock. Our first big donation was stock, so we can liquidate that like that. Grants from family foundations. A lot of family foundations release grants, even though it's just a donation. Family legacy funds. And again, no mutual aid. That's not what we're asking for. Please save that for your communities. So we hope that this series is really helpful. If you have extra spoons and you know people in your life who either are connected to that kind of wealth or maybe know people who are connected to that kind of wealth, this is really a numbers game in terms of fundraising. And the more people that I can get connected to and speak to and get connected to through that person, the more likely we find, our billionaire unicorn. So that's really how we do this. And community and those kinds of connections is really how I am able to find that. Thank you, Margarita Z, although it may be a different person, says in the chat. Thank you. Will you be taking patients from out of state? So, yes, if their insurance transfers, for people whose insurance doesn't transfer, like if they're on Medicaid in another state, we will have a charity care program where we will be able to legally eliminate somebody's medical bills. We'll also have a sliding scale out-of-pocket payment policy. And our charity care program will only be based on statement of need rather than like, what's your income level and blah, blah, blah. So hopefully that will give us a few different inroads to legally provide care to people who may not be able to meet that kind of insurance, commercial insurance, kind of crossing state lines situation. But also if you have insurance that crosses state lines, great. And then they say, amazing, y'all are so knowledgeable. Do people have to be seen in person if they are from outside of New York? If you want your insurance to cover that visit, you do have to have the first visit be in person. You have to have a visit once a year that is in person, and then everything else can be telehealth. So that's really our goal, is to use our in-person location for those in-person appointments and then have kind of a rotating group of clinicians and providers. All of our care managers will actually be remote, but clinicians and providers that are remote part of the time, in office part of the time, so that we can really do as much telehealth as humanly possible as the state and federal government will allow. So contact your reps.
And please contact your reps about telehealth. And while I describe the image we're looking at, could someone drop the link for the clinic sign up in the chat?
Yes, I can do that right now.
So right now we're looking at yet another beautiful image. We've got those geometric flowers made of pills growing out of a hill, and one of them is being blown like a dandelion, putting seeds of pills or seeds of care, if you will, across the navy blue space. And we've got our million match for Hyp+ logo and the text, help us match 1 million by May 2025. Oh, I didn't even mean to switch, but I will keep it switched.
So yeah, you can donate, you can talk to people you know who might know people, tell people just about us. You never really know who actually cares. We often find that, oh, we have this conversation, this person who's been in our life for however long actually knows someone who knows someone, You can become a fundraising volunteer for our campaign. There's a way you can create a profile and kind of have your own little thing that you work with. But please, if you're interested in the clinic, signing up for the clinic waitlist is really helpful because that allows us to gather data on location, insurance type, kind of treatments that you're seeking, kinds of care that you maybe do or don't have, so we can start tracking that a little bit better. We are going to be using that data pretty heavily to inform how we move through this growth process that will be many years of growth. So any information you are willing to provide is very, very helpful for us. And we really do take every single person's needs into consideration. Anyway, just Hyp Care. We really want to center patients. We really want to give staff the time and resources to make complex medical decisions and have those conversations where you're negotiating with your clinician, they're really listening to you. We want to integrate clinical and alternative care, take away some of those hierarchies, and use our business model in the commercial medical industry to sustain community-led programs. So our goal is for all of our community programs to actually be free once our medical care is up and running, because we will have a significant profit margin that is 7 times higher than the national average. It's not huge, but it is something.
We hope you join us in transforming care today. I'll go to the next slide for anyone who wants to snag that QR code. Of course, we're looking for huge amounts to actually make this happen, and that will happen in time, but every little bit of support really does count. So thank you so much for coming to learn tonight and interest in supporting this endeavor. We're going to change everything for everyone.
Well, we'd like to. Yeah. We'll see.
In
We'll see
time.
how
In time.
our next teachings will be about more science, more policy, more kind of snaking through all the fun information that people should know about and understand is all very connected. So this is just our intro. Oh, there's an error for me while trying to submit the clinic form. Ah, good to know. All right, well, we'll get on that. And we will send you all a follow-up email with the clinic form once it is dealt with. And it looks like Miranda has her hand raised.
Hi, I hope that's okay. I know it sounds like maybe there wasn't an official Q&A, and I was like, I'm gonna make it a Q&A if they let me. Could I ask, first of all, this is just such a great model, and I'm very excited about this and really grateful. Beyond, for those of us who don't have connections to billionaires, I was gonna ask like how we can get involved, or if there are ways you're looking for help. And I think you said something about a fundraising volunteer team. Is there a way to find out more about that? Or any other ways to help out, like unpaid roles?
Totally. Feel free to shoot us an email and we'll start having a conversation. We definitely volunteer fundraising is really helpful. Also, we are working on building kind of community think tanks around some of this stuff. It's a little bit slow to start and it's going to be a very, pilot process, but we do really want to start getting folks involved who are very interested. There's also always other things that we're working on. So I think having an individual conversation is probably the best place to begin, right, Al?
Yeah, totally. That would be great. I'm going to pop our email in the chat for anyone who doesn't have it. It is info@hyp-access.org, info@hyp-access.org. And we will be sending out an email to everyone who attended live tonight, as well as adding links to the live, not the live, the recorded YouTube version. So that should be a place where folks can find this type of information. Okay.
Thank you so much.
Cool. I think we're gonna wrap up for the evening. A full half an hour late. Thanks to everyone who stayed. Thanks to everyone who's experiencing this in the future. And we're so grateful and excited for what's to come. All right.
Woohoo.
I'm gonna say good night.